Okay, guys, today we'll be covering another very important topic. Welcome back to Clinically Clear. So let's talk about trachoma. Now, before we go to trachoma, we know it's a chlamydial lesion. So let's look at the etiology first of general chlamydial ocular lesions. See, chlamydia has both virus and bacterial features. That leave it to microbiology. Now, second year is over. We've come to third year. Just remember the species. You have chlamydia trachomatis and you have chlamydia lymphogranulomatis, two species. Now, under chlamydia lymphogranulomatis, you have serovar L1, L2, and L3, which cause something known as LGV conjunctivitis. Now, lymphogranuloma venereum conjunctivitis. Venereum meaning something related to sexual, right? So it shows oculogenital spread. So that is oculogenital spread. So this is LGV conjunctivitis by chlamydia lymphogranulomatis. Then you have another species, main one, chlamydia trachomatis. Under this, serovar A, B, BA, and C, they cause trachoma. Now, trachoma has eye to eye transmission. It shows eye to eye transmission, no genital involvement. Serovar D to K shows oculogenital spread once again. And in serovar D to K, in adults it causes adult inclusion conjunctivitis. In neonates it causes neonatal inclusion conjunctivitis, also known as ophthalmia neonatorum. So A, B, BAC of chlamydia trachomatis causes trachoma, eye to eye transmission. Serovar D to K in adults, adult inclusion conjunctivitis. In neonates, neonatal inclusion conjunctivitis. And chlamydia lymphogranulomatis, serovar L1, L2, L3 causes LGV conjunctivitis. LGV conjunctivitis and inclusion conjunctivitis are both oculogenital spread. Now let's come to the main one, trachoma. Trachoma is also known as Egyptian ophthalmia. Now, what are the risk factors? Risk factors is poor socioeconomic status. In fact, they'll have what in poor conditions when they're living in poverty, there'll be poor hygiene, poor sanitation. So because of that, flies population will be very high. Overcrowding. There's a lot of sharing of towels, kerchiefs, and other handkerchiefs, towels, etc., which can lead to spread of the infection. More common in outdoor occupations than indoor occupation, and the source of the infection is conjunctival secretion. Then, after this, how does it spread? The mode of spread is FFFD. F for fingers, infected fingers. F for fomites like towel and handkerchief. F for flies, which act as vector. And D for direct transmission, which is very rare in case of trachoma, where directly through waterborne or airborne there is transmission of the infection. So, this is about the general features, the source of infection, the mode of spread, and the risk factors. Now, it occurs in two phases. The infection is contracted during childhood. So, the phase 1 is known as acute inflammatory trachoma, where you have an active chlamydial infection during the childhood. Everything is active acute inflammation in this phase. So, if this phase 1 trachoma, active inflammatory trachoma, acute inflammatory trachoma, coexists with another secondary bacterial infection, it is just present as acute mucopurulent conjunctivitis or acute bacterial conjunctivitis. But if this acute inflammatory trachoma is without any other secondary bacterial infection, then what happens is it often goes unnoticed because the symptoms are very mild. Mild watering, mild discharge, foreign body sensation, redness, congestion, sticking, all mild symptoms. All these general conjunctivitis symptoms are very mild, and because of that they go unnoticed. Hence, it is known as trachoma dubium. That is about symptoms. Then we come to signs of acute inflammatory trachoma. Now, signs in trachoma we always go part by part. Conjunctival signs, like any other conjunctivitis, you will have conjunctival congestion. Important here is sago grain follicles only in the upper palpebral conjunctiva. As you can see here, these sago grain follicles, these conjunctival follicles in the upper palpebral conjunctiva. And when I do histopathology of these sago grain follicles, I can see WBCs, I can see histiocytes, and most importantly, I can see multinucleated giant Leber cells. These multinucleated giant Leber cells, histiocytes, WBCs, they're all surrounded by blood vessels. So that is how it appears under histological section. Then next, coming to, and in trachoma, you can have follicles, acute inflammatory trachoma, you can have both follicles as well as papillae. So what is papillae? Papillae is the red velvety appearance because of dilated hypertrophic blood vessels. The blood vessels become dilated and hypertrophic, hence it appears red and velvety. This is about the conjunctival signs. Corneal signs, again, basically what happens from the acute inflammation in the conjunctiva, it can also spread to the cornea. So you'll have corneal inflammation, keratitis. Keratitis often leads to ulceration, corneal ulceration. Then something known as progressive pannus, basically from the conjunctiva, first the infection infiltrates into the cornea, and infiltration is always followed by vascularization. So progressive pannus is when infiltration is followed by vascularization. And the same sago grain conjunctival follicles that I told in the upper palpebral conjunctiva, if they're present in the limbus around the cornea, in the limbal area of the cornea, then they are known as Herbert's follicles. And these Herbert's follicles also, when I do histopathology, I can see the exact same Leber cells. So that is about the signs of acute inflammatory trachoma. As you can see in this diagram, you have papillae, you have sago grain follicles, you have progressive pannus, and you have these Herbert follicles. So that is about acute inflammatory trachoma. So what are the conjunctival signs? Conjunctival congestion, sago grain follicles with Leber cells, and papillae. Whereas corneal signs, keratitis and ulceration, progressive pannus, and Herbert follicles. Phase 2. Now phase 2 is chronic cicatricial trachoma. This occurs in middle age. Phase 1 occurs in young age. Now, chronic cicatricial trachoma is a type 4 hypersensitivity reaction to the chlamydial antigens. So, here it is a chronic inflammatory reaction. Conjunctival signs, conjunctival xerosis, dryness. Then there will be scarring in the form of a linear white band in the upper palpebral conjunctiva between 2/3 and 1/3. This is known as Art's line. And this linear white scar in the upper palpebral conjunctiva is known as Art's line. Then you can also have concretions. What are concretions? Concretions are the white, hard, non-calcareous masses made of epithelial cell debris and mucin in the conjunctiva. No, it is not calcific. Yes, it is hard, it is white, but it is not calcium. It is just made of dead epithelial cell debris and mucin. Then coming to corneal signs. See, corneal signs are the complete opposite of the corneal signs of acute inflammatory trachoma. Corneal ulceration and keratitis now becomes corneal opacity. Hence, it leads to trachomatous blindness. This is the most important complication of trachoma. The most important problem with trachoma is it leads to corneal ulceration, then opacity and blindness. So that is important. Then progressive pannus becomes regressive pannus, known as pannus siccus. Herbert's follicles, they get healed, leaving behind deep pitted scars, known as Herbert pits. So Herbert pits in the limbus. This is about corneal signs. Then coming to lacrimal signs. So what are the lacrimal signs? Chronic dacryocystitis, chronic dacryoadenitis. Remember, all chronic infection. Why? Because it comes from chronic cicatricial trachoma. Then lid signs, very very important is trichiasis. You cannot miss trichiasis in chronic cicatricial trachoma. Trachoma will lead to trichiasis. Then tylosis, thickening of the eyelid, ptosis, drooping of the eyelid, etc. Then this is about the signs of chronic cicatricial trachoma. Type 4 hypersensitivity reaction in the middle age. Conjunctiva, you have xerosis, you have Art's line, you have concretions. Cornea, you have corneal opacity, Herbert pits, and regressive pannus. Chronic dacryoadenitis and chronic dacryocystitis in the lacrimal sac. Trichiasis, tylosis, ptosis, and some other lid conditions also, right? It will end up being correct only. Lid signs. This is about the signs of chronic cicatricial trachoma. Then let's come to the grading. Now, WHO gives something known as Fisto classification for grading of trachoma. Fisto grading. It is a progressive grading. So it starts as acute inflammatory trachoma, right? So F and I, they come under acute inflammatory trachoma. Trachomatous inflammation follicular is F, where what is the condition? At least 5 follicles must be there of more than 0.5 mm in diameter. That is for F. I, trachomatous inflammation intense, where you have inflammatory thickening of the palpebral conjunctiva. That is I. S, trachomatous scarring. You will have arch line, you'll have other white linear scars, scarring of the conjunctiva, etc. There are a lot of scarring. You can write arch line more than enough. Then T for trichiasis. Basically here at least one eyelash should be touching the eyeball, or patient has had an eyelash before which was touching the eyeball and has got it removed, so it has reached the stage of trichiasis. Just because the patient, he or she, does not have an eyelash touching the eyeball right now does not mean they have not reached the stage of TT, that is trachomatous trichiasis, because he or she might have already had trichiasis and then gotten it removed. So as long as one history of at least one eyelash touching the eyeball, then TT, trachomatous trichiasis. Then TO, that is corneal opacity. Basically, it has reached the stage of a corneal opacity causing loss of vision. So grading of trachoma. Trachomatous inflammation follicular, at least 5 follicles of more than 0.5 mm diameter. Trachomatous inflammation intense, thickening of the palpebral conjunctiva. These two come under acute inflammatory trachoma. After that, everything comes under chronic cystatal trachoma. Trachomatous scarring, arch line, trachomatous trichiasis, at least one eyelash touching the eyeball, and trachomatous opacity, that is basically causing vision loss. Diagnosis, you can do clinical diagnosis, grading. You can do lab diagnosis where you'll do ELISA for antibody, PCR for DNA. Then if you take a conjunctival smear and do GM-SAR stain, then it will appear as, you can see the inclusion bodies, you can see the Leber cells, etc. Then coming to the differential diagnosis. Basically, what is the differential diagnosis? The differential diagnosis is if the acute inflammatory trachoma is with more of follicles, then you can often confuse it with viral endemic keratoconjunctivitis, EKC. But the thing is, in viral EKC, the follicles are seen in both the upper palpebral conjunctiva and the lower palpebral conjunctiva, whereas in trachoma, it's mostly in the upper palpebral conjunctiva, the follicles. Then, let's say a patient has acute inflammatory trachoma with more of papillae. Then what will you differentiate it with? You might confuse it with VKC, that is vernal keratoconjunctivitis, which is allergic in nature. But the thing is, in vernal keratoconjunctivitis, there is a ropey white discharge. So there is a ropey white discharge, whereas in trachoma, there is mild mucopurulent discharge. So that is how you differentiate. This is about differential diagnosis. Then treatment of trachoma. Acute inflammatory trachoma, antibiotics are useful. Why? Because it is an active infection. So what is the antibiotic of choice? Oral azithromycin 20 mg per kg. Single dose. Or tetracycline 1% eye ointment 3 to 4 times a day for 6 weeks. Now, this is preferred in pregnant women, children, etc. to avoid the side effects. But otherwise, most commonly used is azithromycin 20 mg per kg single dose, oral. Chronic cystatal trachoma, antibiotics are useless. You have to go for surgical intervention. For conjunctival xerosis, that is dryness, you can give 1% carboxymethyl cellulose eye drops, which are nothing but artificial tears. They act like lubricant. Then, the concretions you can remove using a hypodermic needle. The trichiasis eyelash, you can do electroepilation, chemoepilation, etc. to remove the eyelash surgically. Then, keratoprosthesis is preferred over keratoplasty for corneal opacity to prevent trachomatous blindness. Why is that? Keratoprosthesis is preferred over keratoplasty because of extensive corneal vascularization. In keratoprosthesis, you are doing complete corneal transplant. So that is preferred. So for corneal opacity, you have to do corneal transplantation. So remember, everything in chronic cystatal trachoma is surgical intervention. There is no medical intervention because there is no use of antibiotics because it is a chronic hypersensitivity reaction. It is not the active chlamydial infection. WHO gives something known as safe strategy for prophylaxis. So we'll start from the bottom, E. E for environment. Basically, what happens? Primordial prevention is through environmental measures. Like all the risk factors that I mentioned, complete opposite. Improve water supply, improve hygiene, improve sanitation, use fly control spray, reduce dumping of waste, reduce fecal disposal of like pet feces or any fecal disposal on the just basically it should be proper disposal. You shouldn't litter anywhere because that will attract flies, and flies are horrible for trachoma. They'll cause a lot of transmission. This is primordial prevention, the most grassroots level to the most grassroots method to prevent it. But sometimes that's not enough. You have to go for primary prevention, that is facial hygiene. You have to do recurrent face wash. You have to avoid sharing of towels and handkerchiefs to prevent the spread through fomites. Then secondary prevention, antibiotics. Now, as I told, the antibiotic of choice is oral azithromycin 20 mg per kg single dose. But let's say the pregnant woman or children, then you'll give 1% tetracycline eye ointment for 6 weeks. Whom will you give the antibiotic to? Secondary prevention. You won't just give it to everyone every time. For that, you have to check the prevalence of trachomatous inflammation follicular in 1 to 9-year-old children. When you check the prevalence, if it is more than 10%, then you will give mass prophylaxis where you treat literally everyone. If it is between 5 to 10%, then you will treat the patient and the close contacts. If it is less than 5%, then you will only treat the patients. So this is how you will give antibiotics based on the prevalence. More than 10%, give it to everyone. Mass prophylaxis. 5 to 10%, patient and immediate surroundings. Less than 5%, only for the patient. Tertiary prevention, the last way to prevent trachomatous blindness is nothing but to do the surgery. To do the surgery for the corneal opacity, do keratoprosthesis. For trichiasis, do electrical removal of the electroepilation or chemoepilation of the eyelash that is touching the eyeball. So that is tertiary prevention. So S, surgery, tertiary prevention. A, antibiotic, secondary prevention. F, facial hygiene, primary prevention. And E, environmental measures for primordial prevention. That is it for trachoma. Very important topic. If you have any doubts, please let me know. Thank you for watching.